We'll move on to the next presentation, and that is by Professor Michael Berk from Deakin University, all the way from Melbourne, Australia.
And I'm going to be talking more about bipolar disorder than depression, understanding that it is very similar. So these are my potential conflicts of interest as pertains to this talk. And a good way to understand the whole story of neuroprogression is through the concept of staging. And staging hypothesizes that people with major psychiatric disorders can move through a fairly predictable set of stages, or acknowledging that this is absolutely not universally the case for all people. So people go through a stage where they can start at stage 0, where they're asymptomatic. They can move through stage 1, which is a state of pre-symptomatic at risk, to a first episode in stage 3, recurrence and persistence in stage 3, and treatment resistance in stage 4. And obviously, as clinicians, we're very much motivated in preventing people moving through this stepwise progression. But the staging model predicts a number of things. Firstly, it predicts that as one goes down the stage, there's a greater probability of kindling or of the spontaneous genesis of new episodes. Treatment response declines as one moves through the stages. Functional impairment increases as one moves through the stages. Prognosis tends to decline, and one gets a greater load of cognition and imaging changes as one moves through these stages of illness. But again, we're very interested in wanting to understand, can we protect this? Can we protect the brain against the toxic consequences of the pathways that Brian so clearly explained to us? I just want to start off by giving you a few examples of the impact of illness progression on treatment. So this is a lovely study by Carlos Lopez Yamillo, published a few years ago, where he looked at people who've had a first, second, and third episode of illness. And you can see, while it wasn't significant on all of these various domains of cognition, you can see that the first episode people are pretty close to controls, the second are drifting further away, and the third episode people are drifting further and further away. So every episode of illness that you have is associated with some suggestion of deterioration in cognitive functioning. We also know that as you progress through the stages of illness, the probability of responding to treatment gets worse. There's many studies that now show this. This is true for psychotherapy. It's true for atypical antipsychotics. And I'm just going to show this slide by Alan Swan, which suggests that it's true for lithium. And what you can see illustrated here is that one tends to respond reasonably well to lithium at a low number of episodes. But as number of episodes increase, the probability of responding to lithium starts to go down. There's now very good evidence of brain changes across psychiatric illnesses. And we also have some cross-sectional evidence that treatments have an impact on this. So this is a meta-analysis of a number of studies looking at brain changes in people with bipolar disorder. And you can see significant reductions in the hippocampus. Again, Brian beautifully explained why this might occur. Reductions in the thalamus, and an increase in the size of the ventricles. But what you can see here, in the red is not taking lithium, and blue is taking lithium, that at least in the thalamus, there's evidence that taking lithium protects this, and there's a trend for reduced ventricular size and hippocampal volumes in people taking lithium. But this has never been shown longitudinally in a randomized controlled design. This is only cross-sectional association studies. And so this takes me to what we're trying to do in our study. Just to also make the point in terms of atypical antipsychotics, that with typical antipsychotics, one tends to see very little protection of brain volumes in people taking atypical antipsychotics, and an uncertain picture in terms of benefit in the hippocampus and in ventricular size in people taking atypical antipsychotics. So it really is an open question as to whether these agents really do change illness course, whether they change markers of progression. And the other open question is which of the agents that we have from a neuroprotective perspective are better, lithium or quetiapine. So this was the aim of our study. This is a study conducted in a first episode bipolar cohort, and this was a study done at Origin Youth Health in Melbourne, and I'm very glad my colleague Ashwin Ratish, who is a collaborator in the study, is here. And what we tried to do in the study is to look in the first 12 months after a first manic episode whether there were any changes in anatomy or cognition and whether these were prevented by lithium or quetiapine. Our secondary aims were clinical, and the reason why we put clinical changes as secondary is we thought that we wouldn't be powered clinically to see significant clinical changes, knowing the sample size that is required for most of the clinical trials in bipolar disorder. I want to start off by saying one of the things I love about research is that one is always surprised. One never finds what one thinks one's going to find, and certainly this was the case in almost everything we found in this study. So firstly, in cognition, and I'm going to show you two of the domains of cognition which were changed by treatment. In both of these, lithium was superior to quetiapine. So if you look at fast fluency, you can see no change in the quetiapine group, but a significant improvement in fast fluency in the lithium-treated group. And when one looks at working memory, in this case, this is errors on a maze test, you can see a reduction in errors over the 12 months of treatment with lithium, but no change in the quetiapine group. This surprised us, but again, what I'll show you now is that these data are congruent with pretty much everything else we found in the study. The other agent that we're interested in is N-acetylcysteine, which has interesting effects at protecting against oxidative stress, has some anti-inflammatory effects, and also has indirect effects on glutamate transmission, which is again very much germane to the pathways that Brian spoke about earlier. And we've done 2 clinical trials in schizophrenia and bipolar disorder, and when we looked at cognition and we pooled those 2 groups, this is in individuals who had psychosis, you can see an improvement again in working memory. So the only domain that came up positive in the lithium study was working memory. The only domain that comes up positive with our N-acetylcysteine is working memory. And you can see this improvement in working memory after 6 months of treatment with NAC compared to controls. Let's get back to the lithium studies. And when we looked at changes in brain volume, we saw a significant effect, but not what we expected to find. So we expected to find gray matter changes and hippocampal changes, but that's not what we found. What we found is significant changes in white matter volume favoring lithium. So here you can see a reduction in white matter volume in the quetiapine-treated group, no change in the controls. We had a control group as well. So the quetiapine group did not separate from controls, suggesting that quetiapine neither helped nor worsened this, but you can see a significant protective effect of lithium in terms of white matter volume. Now, with the benefit of a retrospectoscope, there's really good reasons for understanding why lithium might affect white matter. Lithium has quite powerful effects in vitro on myelin, and in retrospect, this story makes sense. But a priori, this was not what we were expecting to find. When we looked at spectroscopy, and there are many metabolites that you can see in acetyl aspartate, choline, creatine, Mania, and inositol, and we looked at the hippocampus as our region of interest, we saw significant benefits in all of these measures for lithium. So you can see on choline an increase in lithium, in N-acetyl aspartate, which is again is a marker of neuronal protection, increase in lithium, and in creatine, which like choline is a marker of bioenergetics, an increase in lithium, no change in the quetiapine group. Again, suggesting a significant neuroprotective effect of lithium on bioenergetics, and again, Brian explained why you would expect bioenergetics to be compromised through these pathways. And lastly, when we looked at resting state connectivity, we saw a significant normalization with lithium-treated people, but no change in the quetiapine-treated group. compared to controls. Now, as I said right in the beginning, we never expected to see changes clinically. And this very highly powered study by Andy Nierenberg with a sample size of 240, remember we only had 30 people in each of our groups, we thought there's no point even bothering to analyze the clinical data because we had no chance of finding anything. So this highly powered study running over 6 months showed no difference at all between lithium and quetiapine. However, let me just make 2 points about Andy's study compared to ours. Ours is a first episode Mania study. Andy's study is a chronic cohort of people who were depressed at study entry. So there are very important differences in terms of the clinical cohort. So as I said, we didn't think it was even worth our while sending the data to be analyzed. And what we did is our imaging people said, please send us the stuff to look at as a covariate. 2 weeks later, the phone rings, and our imaging people say, you really need to look at these data. There's something interesting going on there. And so we did. And what we found was really very striking and very surprising to us. So if you look over the 1 year of the study, over the period in light gray is lithium, and in dark is quetiapine. So after about 6 months, the quetiapine group starts to deteriorate and become more unwell, and the lithium group stays well. So this is psychotic symptoms, Beef Psychiatric Rating Scale. Lithium is a better antipsychotic in bipolar disorder than quetiapine. Who would have expected that? We certainly didn't. When you look at depression, you can see depression scores starting to increase. So you have a score in the quetiapine group of about 13, moderately ill, and in the lithium group, you have scores of 2, which is unheard of in a clinical trial and is better than most of us in this room today. On bipolar depression rating scale, you see exactly the same. The lithium group is staying well, the quetiapine group is getting worse. On manic symptoms, you see exactly the same. Quetiapine group's getting worse. On clinical global impression scores for depression, same story. On CGI for mania, same story. And on overall clinical global impression scores, same story. So let me just unpack this slide as an indicator. So 1 on a CGI is normal, not at all ill, and a score of about 3.5 is somewhere around moderately ill for the quetiapine group. So everybody, pretty much the mean CGI score in the lithium group was 1.4, normal, not at all ill. These are people who would be undistinguishable from the normal population 1 year after an index diagnosis of bipolar disorder. These are strikingly divergent findings. Measures of functioning, the SOFAS, declining in the quetiapine group, global assessment of functioning, declining in the quetiapine group. And let me just put this all into context with some papers that were published subsequently. Now, prior to the study, the data really was in equipoise. The literature really suggested that these agents were roughly comparable. But there's a number of really good quality studies that have come out subsequently suggesting that this really isn't the case. So firstly, this paper came out by Hayes, which was a non-randomized cohort looking at time to treatment failure, comparing lithium, olanzapine, valproate, and quetiapine. And you can see that lithium is just better than everything else, at least in his study. Another paper came out a few months ago looking at lithium responsiveness and after first versus second treatment. And what you can see is that excellent response is much more common after a first treatment than after a second treatment. Again, reinforcing the idea that you have a window of opportunity in the early stages of the illness where you're going to have very high levels of lithium responsivity, and if you do not treat with the best agent at the earlier stages of the disorder, you're going to be in trouble. So let me just summarize where we're at in terms of the field. I think that these clinical data reinforce the notion that neuroprotection does occur, and so that neuroprogression occurs, and it's progressive from the earliest stages of the illness. This study, I think, offers a window of hope, suggesting that early intervention, early in the illness course, has the potential to interrupt disease cascade. It confirms that lithium remains our treatment of choice. And again, our data supports the use of lithium from the first episode, which is, again, a bit of a change in terms of paradigms in some centers, which argued that lithium should be held in reserve until a person's had a number of episodes. Our data suggests that you need to be using it right from the get-go. So I'm going to stop at this point, and I'd be happy to take any questions that you might have.
Michael, I have a question for you.
Angelos.
What was the dose of quetiapine?
So this was at clinician discretion. So the mean dose was about 400 milligrams, but the clinicians could choose what dose they chose to use.
So they could have gone higher
Or lower,
opted
depending
lower.
on tolerability and efficacy.
Do you have any idea about the dose range that was used after the study was done?
I could just give you the mean, which is around 400.
About 400 is
Yeah.
the mean. Okay. Any other questions? Yes, sir.
Roger.
Michael, do you have any idea why they split after 6 months rather than earlier, if you like? Why do you think the cumulative effect occurred then?
That's an excellent question. My primary hypothesis is that this is kind of when you'd be expecting a next episode to be occurring in terms of the natural history of the illness. And my guess is that this is preventing what would the next episode from occurring in a way that quetiapine was unable to do so. But yes?
Sorry, I just wanted to call, probably could atypicals be causing people to be more likely to get recurrence, is the other argument.
Correct. So the second hypothesis is that atypicals could be increasing your risk, but there isn't other evidence suggest that that's the case. And the third hypothesis is that maybe coming off lithium isn't a good idea. So there are three hypotheses. I'd like to believe the prophylactic hypothesis, but one always has to entertain all the alternative hypotheses.
Regarding your last slide on the reintroduction of lithium, that the response is much poorer than when you have a clinical situation that is, like I recently had when the patient has acute renal failure and I had to discontinue lithium. Do you think there is no point in reintroducing lithium and the patient will come out worse, or do you think it's still worth reintroducing?
This is a very complex issue. So the issue of renal toxicity and lithium, and at what point one bails from lithium therapy in the context of balancing the benefit of lithium as against the risks to the kidney. I think most, this is a highly individualized decision done always in conjunction with a renal specialist. But I don't think that many clinicians would be pursuing lithium to the point of significantly clinically compromised renal function.
The renal failure was due to another reason, but of course I was called by the nephrologist and had to discontinue lithium.
So if it's a reversible cause, a nephrotic syndrome, something that's going to reverse, I think under those circumstances, one might want to rethink lithium if an exogenous cause of renal dysfunction is treated, managed, and disappears. The bigger issue is what happens in the context of lithium-induced renal dysfunction. That's a much more uncertain issue.
We have data to show that the second phase response is improved with early lithium?
No, I don't have data on second phase response.
Okay, thank you,
you.
Michael.